total corneal wavefront. And when we think about the use of excimer laser, we have two categories that we use to see, so the cosmetic or the therapeutic use of the laser. When we have regular corneas and the patient comes just to make free of glasses, the ablation profile is quite easy and we can correct with such a simple ablation profile. However, when we have a more complex cornea, we are dealing then with high order aberrations, and sometimes we only want to correct those high order aberrations. So here with the new platforms, we can assess those two situations in different ways, both for cosmetic and therapeutic excimer laser surgery. And then we have the corneal, or we had the corneal wavefront and the ocular wavefront. But so far, what we have was the corneal wavefront based on the topography. So the data was from the topography, and this was done very nicely from Sirius, the Scheimpflug and Placido combination. And we also have, which is fantastic, the ocular wavefront. So with the ocular wavefront, the name already says, we take the whole eye as a measure. And of course, the measures are different. We will speak, and I will show you this later. But now, what we have is the total corneal wavefront. So it's not only the anterior surface, not the whole eye. We can take the whole cornea as a measure thanks to the MS-39. So when we see about those corneas with irregularities, some of them are keratoconus. I've already heard, okay, I do a perfect DALK from some colleagues, and I don't even have astigmatism. And sometimes we are lucky enough to have such a good outcome with 0.8, 0.5, so very low astigmatism. But that's not always the case. So this is a paper from this year and AJO showing that even with femto, we can have up to 6 diopters of astigmatism. So I know some of you are very nice surgeons, but that's the average, 6 diopters, 3 diopters. So we have to take into account also other strategies for treating such corneas. One of them is the excimer laser. However, you know, when we have a regular cornea with keratoconus, we do not want to additionally impact the biomechanics of the cornea. And we also have other factors. So the more we ablate, the more inflammation we can cause, and therefore eventually more haze. So we always try to put the ablation down, so to minimize the ablation profile. And we can do this in many other ways, but the laser actually comes for the fine-tuning in most of the cases. So we can improve the high-order aberrations and the low-order aberrations before surgery, the excimer, I mean, or after with other procedures. And here is a very beautiful image from Shadi Awad, and he is leading this process together with Susan Jacob about the femto cares. So this is a nice way to address those very irregular corneas before excimer laser, for example. Another way to address those irregularities is what we call the PACE cross-linking, so the PTK assisted customized epi-on cross-linking, and we can have in such cases a very nice flattening without the tissue removal. So why not to associate this technology? So here's an example before and after the surgery, just 1 month after the surgery, and here you can see as well another case with a visual acuity of 0.4. And when we look at the point spread function from the MS-39 and together with the here's MS-39 only, we can see these very high order aberrations. Of course, the cross-linking is done to stabilize the cornea, but now we can also improve the cornea, and that's the result 1 year after the surgery. There was a huge coupling effect, steepening and flattening of the cornea. And you see also that the visual acuity improved a lot, the corrected visual acuity. And again, when we look to the point spread function from MS39 and pyramids together, we see the improvement. So not only the visual acuity improved, but also, and most importantly, probably the quality of vision improved a lot, and that we can see better here. So this combination was possible due to this very nice combination about the laser cross-linking devices and diagnostics. And if you want to hear more all of those procedures that remodel the cornea without the use of excimer, so there are additional treatments, we'll speak about this tomorrow. But now coming back to the excimer, so what do we have, or what did we have so far? We have, as I said, the ocular wavefront, so the whole eye treatment, and we had the anterior corneal wavefront. So I show you some examples how these can compensate each other. So here you see the ocular wavefront aberration profiles and the anterior corneal wavefront, and you see that the high order aberrations are a bit lower when we look at the ocular wavefront. Why? Because there is an internal component. And what is internal component here? The internal component here is the posterior surface of the cornea, the lens, and everything between the lens and the retina, including the retina. That's the internal. And so when we think about refractive laser surgery, we can think, and now it's a bit easier to understand because we have the concept of the posterior astigmatism as well. And exactly this happened with the high order aberrations. So the posterior astigmatism, if it's in the same axis, would compensate on the other way around. So you see a cornea now which is highly curved on its back surface. And then you see the anterior radius, and you see also the posterior radius. So they are very different. And a very nice image from MS39 is the gyoplanation. I'm not sure how to speak this in English. But you can see how the posterior surface goes forward. And of course, this has an impact on the anterior surface, but also on the posterior surface of the cornea. And we have to take this into account. So when we put both of them together, we see not only that they are very different, but the most important is they coincide. So one compensates the other. And that's why when we take into account also the posterior surface, we can end up saving a lot of tissue in some cases, not in all cases, but in most of the cases. And here was shown a paper in 2018 where the posterior surface was also taken into account. That was a 25 micra in safe tissue. And we have to remember 25 might seem not that much, but if we keep on the limit of 50, so that's half of it. So it gives us a lot of place to the treatment. So what we had so far was, as I said, the anterior surface that could be treated and the ocular as a whole. And as I also said, we included the lens and all the other parameters inside. On top of that, and that works very good. But on top of that, sometimes when we have patients with small people, we cannot get access to all of this data. We can only get data via the pupil size. So that was a limitation of ocular wavefront, and that's why it's very nice, especially on those phakic patients with irregular corneas, to have the total corneal wavefront. So how do we look this on the laser platform? So it doesn't change what you are used to see. So this is the Schwind ablation profile, and you see up there what we see differently is that we see the corneal wave CW, And when we look at it, we are taking now into consideration the anterior and the posterior surface of the eye. Why is this important? Again, so here's an example how the anterior surface and the posterior surface can compensate and make us save a bit of tissue. So you see the anterior surface coma has 4.91, 71 degrees. And when we look at the posterior surface, we have 1 and something, 1.2 around, but on the other way around. So treating those both components will make the ablation, in this case, lower, and that's very helpful on keratoconus patients. So when we export the data now from MS39 to the Schwinn platform, what we see is that not only all the aberrations information, the OPD is transferred, but also very nice is that now we have the epithelial thickness exported as well. So it goes automatically to the laser, not only the OPD, but also the epithelial thickness of this specific patient. So the central and the peripheral epithelial thickness. That's an example how the mixture of the pyramids with the MS39 looks like. And now we can have on the left-hand side the ocular wavefront and all the aberrations of the whole eye. Now with MS39, just the cornea, and now internal means not only posterior surface and lens, but rather only internal. And we can select as well the ablations or deselect. So you see some red signs on the first line of the aberration. So now I deselect the low order aberrations, and then you can have an idea how would the treatment also be like if you only correct the high order aberrations. So in summary, you can have the total corneal wavefront, and when we select up there, we can just select the red. If you see up left, you'll see the total corneal wavefront, or we can select no, I want to see just the high order aberrations of the anterior surface, or no, only the posterior surface, and even the epithelium can be shown in such a form as well. By the way, the refraction of the epithelium is a nice tool as well that we can have there. So plus 19, 0.25, that's the epithelial refraction. And sometimes this can explain some cases that we didn't have a nice explanation why it changes the direction post-operatively. So now with such combination, we can have really a full customization, because we can not only correct the anterior, the whole eye, and the corneas as a whole. And on top of this, this would be too long, but, and Ryan spoke about the epithelium, but we can, with such technology, also assess which procedure we will take, transPRK, PRK, trans PTK, or so on. So I'll show you some cases. This is a patient with irregular astigmatism after LASIK. And you see down there the refraction of the left eye, just down left, it's 0.25 minus 0.50. That was the subjective refraction. But the patient was not happy with his visual acuity. So here we can see just the cornea. I'm showing here the anterior, the posterior, and the total corneal wavefront. And this is specifically case. This is also the image from MS39. We can see the pupil size in different conditions. And this is specifically case we could have also done an ocular wavefront because the pupil is big enough, but that's not always the case. And here you see also the ablation profile. And by correcting only the high order aberrations, the ablation zone or the ablation depth was only 27 micron. Here's another case now, a keratoconus after cross-linking with with such irregularity, and also I don't have in my mind now, but probably intolerant to contact lens, in which a transPRK was to be planned. And here I wanted to compare the three ablation profiles, so you can see. So on the left-hand side, the total corneal wavefront using the data from MS39, and then the only anterior cornea wavefront in the middle, and on the right-hand side, the ocular, so considering the whole eye. And what I would like to, that's not always the case, but in this case, the total corneal wavefront, and you see here how the depth of ablation in each of those treatments were. In this case, the total corneal wavefront was a bit lower. So we can really analyze all the parameters from the cornea and choose what's the best one for each patient. We were speaking about IOLs. That's a nice example. And when IOL comes to the market, we sometimes also ask ourselves, okay, is this a EDOF? Is this a multifocal? Or because sometimes it's not clear, the information for us. So this is a patient with a IOL. You see on the left-hand side, the whole eye aberration, in the center, the cornea. On the right, the just internal. So you see that the aberrations, or this difference, comes basically from the inner part of the eye, so the IOL. And the reason why is that this patient had this asymmetric segmental EDOF IOL, but when you look at it, you see, at least for me, it looks more like a bifocal than an EDOF. Of course, there is the EDOF component, but this helps us to understand the optics of the IOL as well, so the combination of P-Ramis and MS39. So in this case, if the patient had some corneal irregularity, we would rather not correct the ocular wavefront, otherwise we would also be correcting the internal aberrations. So that's exactly a good example how the total corneal wavefront can be very helpful on those cases in which we want to keep the aberration as it is and just improve the irregularities on the cornea. Lastly, I have 2 minutes. I will just show the importance and why we do all of those treatments in cornea, in irregular cornea. So this is an example of preoperative 2.19 high order aberration, RMS, and postoperatively 118. And you see the refraction is not close to emetropia, and that's not our purpose. The purpose, as I said, is to really improve the quality of vision. So here you can see the topographies, but here is the main purpose, to improve the corrected visual acuity. And this now also with those screens is very nice to show the patients before and after the surgery, and they understand very easily the letters and also the point spread function. So as a final message, for the first time, now we do not only have to rely on either the total ocular data or the whole eye, which would include the cornea and the lens, or only on the anterior cornea data. So now the total corneal wavefront is possible, and very nicely, regardless of the pupil size, of course. This, of course, expands the options we have for excimer therapeutic surgery, especially in irregular corneas for phakic eyes. And just to remember that when we do such treatments in such irregular corneas, our purpose is to improve the quality of vision, especially on those very irregular corneas. Thank you very much.